Georgia. I am over all the revenue cycle of HIM, patient financial services, a little hospital and physician, patient access services, the switchboard, and revenue integrity, and all of that good stuff. The systems that we're using, we actually have multiple. So we're Cerner clinicals as well as Cerner medical records. We have IDX for registration and scheduling, as well as my physician billing and collections, and then my hospital billing and collections is HealthQuest. So we have lots of wonderful systems that we're running.
Andrea.
Hi, welcome everybody.
Okay, sorry. Hi, Andrea Mejia. I'm the Executive Director for Patient Financial Care with Piedmont Healthcare. And you may be wondering, what does that mean? So I work with all the registration, patient access for the health system, in addition to the Customer Solutions Center, which covers the professional billing and hospital billing. We are an Epic shop, so we do billing on Epic for all our services that we support. And I have been with Piedmont for about 9 years now.
Yeah.
So again, my name is Matt Fisher. I'm the Director of the Customer Solutions Center for Piedmont Healthcare. I'm the Director of what we consider the SBO, the Single Billing Office, so I oversee everything from physicians billing and hospital billing for a lot of hospitals, over 2,000 physicians. So I oversee charity and financial aid, and standard indexing for the entire organization. I've been with Piedmont for about 4.5 years now.
Hey everyone, my name is Adam Gobin. I am the Assistant Vice President of the medical group of WellStar's WellStar Health System. WellStar in itself is an 11-hospital health system, but the medical group has 1,200 plus providers. So I'm over that for RevCycle PD billing. We're on Epic. We've been on Epic for 8 years. Professional billing at WellStar is very unique, and there's a lot of decentralized functions. So we have some centralized charge capture, and then everything else downstream: AR, claims processing, refunds,
And Richard.
Good afternoon, everybody. Richard Flores. I'm Vice President for Revenue Cycle Operations for the Hospital Division for Kindred Healthcare. My span of responsibility is the Hospital Division, which is the long-term acute care facilities. We also have inpatient rehab facilities. We have behavioral health services. So we are one of the largest, if not the largest, post-acute provider of healthcare based in Louisville, Kentucky. I've been with Kindred for a little bit over 2 years now. So this is my first foray into post-acute, and I'm still learning, still adjusting, but I've got a great team and it's a great company, and I'm glad I could join y'all via Zoom. I apologize, I would love to be there in person, but the last minute scheduling changed. So thank you, Georgia HFMA, for the invitation and for being tolerant of the scheduling change.
Thank you. And post-pandemic, we probably would not have had this, right? So we're super excited. Unless it was like a celebrity that we had to bring in to attend. So thank you. So when we talked about this panel, we talked about kind of the traditional, what keeps us up at night. And so the new thing is working from home post-pandemic, right? So we're going to talk about working from home, but then, the traditional old denials, right? Has it gone away? It hasn't. So we're going to go into that. And we'll talk about telehealth because that's also new, but maybe a little bit of a twist on telehealth, not just what you've heard before. And then some different things about systems and interoperability, and then we'll wrap it up. Okay, so I'm going to start off with just talking about, working from home. We've been talking about productivity, and things are now changing now that the vaccine is here and people are getting vaccinated and things are opening up. And so we want to talk about just engagement and approaches that different organizations have related to working from home. So I'm going to start with Jennifer and just ask what you're using to gauge productivity and quality for your teams.
So interestingly, when I got there, there was productivity measures that were put in a couple of years prior to me being there. And then there was a directive, the old directives, let's take collections, for example. If you don't meet your 55 accounts per day, you're going to get written up. Well, guess what? The team figured out ways around so that they could get their little checks so that they worked their 55 accounts a day, but they weren't really doing anything with it. I kind of call it paper pushing. They were just pushing stuff all around. So we've actually sort of taken a little bit of a step back from those productivity numbers, especially on the collection side, just because of the fact that, just checking that box and saying that you worked an account, but you actually didn't do anything is not benefiting the organization. So my mantra since I've started here, it's a little different than what I expected, but we kind of are going back to revenue cycle 101 basics and almost retraining the entire revenue cycle from patient access, from HIM, from the business office, everywhere, to really get back to the basics and take quality into effect first and then go back to productivity. So I will say the CBO side is probably a little slower to uptake, whereas the patient access team has really stepped up to the plate. We actually have some pretty good systems on my call center to be able to track the number of calls, average call answering time, drop rates, things along those lines. I will say during COVID and being one of the state testing facilities, my call center just about blew up. We were getting upwards of 4,000 calls a day with people to answer those 4,000 calls. You can imagine it didn't go well. But we've learned a lot, and productivity, you have to just really take into account. Just checking off a number is not enough. You have to make sure that your team is actually doing quality work and making sure that they're getting things done. I'm sure on the patient access side, you all have tools like an AccuReg or something along those lines where they check your registrations and they check your eligibility. But if they're not actually reading the stuff, then again, you're still not getting things done. So they might have had a 98% first pass rate of having your registration accuracy, but if down the road, they didn't really check it because it looks like it went through appropriately, but oh, hey, guess what? They had a Medicare replacement. We have to do all the rebuild and rework on the back end. So you really have to make sure you're monitoring not only the amount of checks that they're doing, but also the quality of checks that they're doing.
So the other thing I meant to mention is that if you guys, we want this to be interactive, and there are some questions that the panel will have for you guys. So feel free to jump in anytime, raise your hand if you want us to stop at a specific topic. I'm going to move to Adam and ask whether or not this new working from home business model is going to be your long-term approach, or you guys are going to bring people back in.
Thank you. So for us, we, and just so everybody knows, every time I say us or we, I'm talking about Ashley Hill over there in pink, because she does all the work. But for us, as soon as all of the staff members went to work from home, trying to look to the left because I keep looking this way, we had a 6 to 8% increase in productivity as soon as they right off the bat. It was super incredible. We had a 12-point increase in employee engagement as well. So we figured out, all right, how do we keep up this momentum of making sure these people are continuing to just work widgets, right? That's their jobs. How do we keep them engaged? So the biggest thing for us was connection. We do a monthly pulse survey and realize what they really care about is just development. We can start talking about development in our monthly all staff meetings and get them engaged. They'll be engaged at work and it'll help with the productivity. So we've seen that. So I urge, like monthly pulse checks with your teams. It helps with the employee engagement pieces, helps them to stay a little bit focused. We're going to do a hybrid model because there are certain things in healthcare, as most of you know, which is why we have so many vendors that can help us. That's going to be paper driven and all those types of things. So we have a hybrid model today that'll continue to stay until healthcare gets back into the screaming 2000s to get a little more automated. So, we'll have people rotating back into the office to do payment posting and all those different things from a manual perspective. But then we also are struggling with trying to get practice outreach teams going out to the provider offices to sit shoulder to shoulder with people to remind them about point of service cash collections. That dropped significantly because people were so used to not collecting point of service cash collections during the pandemic. Now it's kind of like, don't forget, we gotta collect point of service cash collections. So that's been trying to figure out and navigate how we bring back sort of a hybrid model because there is a necessity at the same time. So.
Thank you. Richard, did you want to share your organization's approach?
Yes, thank you. Well, we have taken the position, we're not, haven't made the definitive decision to remain as a work from home business model. At this point, what we did do is we deem it currently as a privilege to work from home, meaning that as long as productivity measures, quality measures, et cetera, are met, that work from home model can continue to be the the preferred model for the individual employees. However, we had should step back and say we had 3 centralized business offices across the country. We have one in Los Angeles, we have one in Houston, Texas, and one here in Louisville, Kentucky. So like everybody else, we mobilized this workforce rapidly to work from home. But what it did is expose not having visibility or sight lines to the productivity of the workforce. And while we had some of our applications for both collection, follow-up, and billing have components of productivity, we really didn't have anything that tied everything together. So we're in the process of revisiting those applications with our third-party partners on really optimizing that technology. But we also have made a recent investment into a telephony solution, which really gives us across the enterprise statistics related to productivity and quality, to name a few. So it gives us, just the very basics we didn't really have as far as the number of incoming calls, abandonment rates, hold times, et cetera. So now we feel like we're going to have the tools, and we're just getting this underway. We're going to phase it in with our frontline area, or our centralized admissions department, and our clinical appropriate management team. And then we'll work our way back to the business, up to the CBOs. So we're excited about it. It's got some capabilities that our existing technology would not have, including the ability to barge in if we wanted to on a phone call, if we needed to, if it really went south and we had to intervene. We can whisper and do coaching. There's just so many more capabilities, and we're actually trying to really slow down because we've gone from really having not a lot of technology around that front, around call center technology, to really having almost too much. So we're trying to keep it simple as we look to roll it out.
Okay, thank you. Thanks so much. So I don't know about you guys, but revenue was down. So my CFO was, knocking on everybody's door saying we need to figure out where we're going to save money, right? Expenses, you need to look at them. So cost savings, and aside from space. So we thought, isn't it enough to just say, you guys can take some of this space? No. So aside from space, how else can we save money in our organization? So I'm going to ask Jennifer to share how she looked at that.
So obviously with the work from home, you're not having to pay for paper, you're not having to pay for toner, you're not having to pay for coffee, all of those things. And if you really take into account all of those small little things that you just kind of take for granted because they just show up every 2 weeks or every week, however often your supplies are, it's amazing how much of those little things actually add up. As well as, your Wi-Fi's at your offices. With having less people there, your Wi-Fi's work better. You just don't have as much load on the system. So that's been a significant improvement because things are going faster in your systems. Just in our instance, our systems would go down, but really bog down a lot, especially during high traffic times. So having those people outside now in the organization or outside of their homes has really sped things up. So those are some of the cost savings that we've just, things you wouldn't think of that we've really noticed and seen. Printers are lasting a lot longer. We're not having to get serviced as often. Just something as simple as that, it's a huge cost savings to the organization. And we're finding ways that maybe we don't need that paper so much anymore. Let's find different ways to send things electronically, or to send things PDFs as opposed to printing, faxing, and then throwing things in the shred bin. So that now we're having to pay the shred bin company to come and shred all of our paper. So really thinking outside the box in all different kinds of ways to get things out there and transmit it without that physical people or physical things that you have to do.
Anyone else want to share their thoughts around expense savings? On the panel or off the panel?
I think one of the other things you're going to realize is the expense savings in commercial real estate for the organizations that no longer have a physical presence. Today is a bad day and time to be in commercial real estate, especially with all the organizations sending people home and working from home. There's organizations that are saving $10,000 a year not having a physical presence, in space, and having their staff work from home. So you've got that savings as well in just your physical location that you're no longer in.
But I also read something about how talking about, moving the RevCycle people, moving those people that aren't those clinic-facing people out of hospital facilities or out of things along those lines. Now you can use those spaces for clinical, so you're going to hopefully increase potential revenue or expand footprint of clinical areas that maybe would have been tight before and didn't have somewhere that they had to go. Maybe they were doing like clinic shares in medical office buildings. So that's obviously a savings as well, because now that you've got these people maybe out of the footprint of the hospital, you can actually bring in more revenue producing facilities into the organization. That also something significant.
Can you actually elaborate on that a little more? Because I wholeheartedly agree with you. I'd like to understand what you're seeing as you're trying to reuse space, and yeah, you don't need them for revenue cycle people, but maybe you need them, for some clinical department. How is that translating on the operating front?
Well, I can tell you, so for my personal experience, right now, my HIM team, were able to really transition so many of them to home-based. Where they are physically located now is actually in our medical office building. And we have clinics that some doctors are having to do all of their patients out of one exam room. So you can imagine we've got 3 doctors trying to filter all their patients through one exam room. Now being able to, so you can't, obviously you can't book a full schedule for each position, because there's just quite literally, you can't run that many patients through. So now having those rooms available in the actual medical office building, it's not like they're in some weird obscure place, down in the dungeon of the hospital. So now we're able to open those up, and we're able to expand the capability and the capacity for those physicians to be able to see more patients and have better patient throughput. So that's one of the areas where we're really starting to see things like that, as well as even just expanding some of our service lines so that we could start to provide more services that maybe we just weren't able to do because we didn't have the space before, because we didn't have the clinic space. We're able to transition some of our research teams to more research focused areas, which then opens up the spots that they were previously using for clinical, for their research, to more of the clinical teams, again, getting more capacity here to some more positions. So that's kind of how we're seeing it right now.
I think that makes sense. One of the things I want to say is that it probably offers, for a shift that has been happening for many, many years, in organizations that were slow to make the change, this has offered the opportunity to push that a little bit harder, right? Because administrative functions have been moving out of the clinical space for a very long time. It's organizations that really have been kind of slow to the move, that now this gives them the opportunity to say, we really need to make this happen, and let's get the clinical space, especially for organizations that can afford to build new buildings or open up clinics in other places. If they want to have the opportunity to have that space within their existing space, move the administrative functions outside. And so instead of finding additional space, they're just moving them home, right? So they're home, that's freed up the space. And now they can do what some organizations have done several years ago, right? So that's really true. Anything else on that?
Be interested in hearing from the gentleman.
Okay, Richard? Do you want to share? Did you happen to hear that conversation?
Can you repeat the question?
Okay, so Richard, some of the audience wanted to know what your thoughts were related to moving people from home, possibly the opportunity of using, getting more clinical use of that space for clinical services rather than administrative services.
Well, two of our CBOs were actually not in the hospital settings. One was a medical office building, and one was at our corporate office. It actually left a facility and came to our corporate office. So our hospital in Los Angeles, I think it's looking to be occupied by in some cases non-clinical services in the hospital. It's in the basement of a particular hospital. So, the one thing I forgot to mention, though, while we may not use all that space, excess capacity, we have given the directive to maintain at least 30% of that capacity within the CBOs for onboarding, for training, for the occasional in-services. Because I think we're going to talk about keeping staff motivated. I think in some cases, keeping the staff motivated is bringing them in, albeit, with the proper social distancing and safety measures, but to celebrate, successes, birthdays, whatever. So we haven't used, at least in our case, that space for excess capacity for clinical means at this point.
Thank you. So you brought us right into that, the topic of how do you keep staff motivated? So I'd love to hear, because that's really the challenge, right? So Matt, you want to help us with that?
Sure. So, I mean, remote work has been something that has been around for quite some time, but it's not been really adopted fully for quite some time. There's still a lot of old school mentality out there about working from home. To Adam's point earlier, he saw engagement increase. We also saw engagement increase with people at home because that's been something that they've been asking for years and years. Well, once we finally saw them go home, the engagement increased, but it was very short-lived. At that point, people realized that they're in their own home, they're in their own setting, they're wearing their PJs and sweatshirts to, crawl out of bed every day. And running the center that I run, I run the customer service call center. Time and attendance has always been a really challenge for us as leaders. So we figured, okay, we'll send them home. Time and attendance is no longer going to be a problem. It's still a problem, and I don't understand it. That's one of the things that baffles us. Is time and attendance is still a problem. You roll out of bed, you grab a cup of coffee, you log in your computer, and you get to work. But we realize that there's so much more to it because these people still have lives, and they're taking kids to school and they're doing all their daily lives. So the increase in engagement was very short-lived. So we've got to make an intentional effort. We've made an intentional effort to try and meet them where they want to be met. Maybe it's something as simple as sending a text message to a staff member, knowing that they're on a phone with the patient, and say, "Is there anything I can do for you today?" And they'll text back either then or later and say, "Hey, I need X, Y, and Z." No, I'm good. Thanks for reaching out. So the increased engagement, and to maintain that increased engagement means constant contact with those staff members that are working from home, whether that's FaceTime, text messages, cell phone calls to them, schedule FaceTimes, schedule one-on-one with those staff members, and then constant praise and recognition for what they do well. Since they're disconnected with us physically, any compliment or praise that we get in from a patient or an internal customer across the organization, we really have to play that up through our internal recognition system. We partnered with, at least at Piedmont, we partnered with marketing. I have no problem dropping swag in the mail in UPS and mailing it out to their personal addresses, mailing them something home. It's always nice to get something home, but I think the key to it is constant contact with those staff. Sure.
Do you have a policy on whether or not they want to come back into the office? Is it the same for everyone? And it's the people if they select to, let's say, go back into the office?
That's not about things for that one. So we at Piedmont, we actually have made the decision to not go back in the office. So all the way from our VP of revenue cycle down to our frontline biller is going to be remote. Now we still have office space in Atlanta and in Athens, but that has been consolidated. So when we're talking about consolidating space, we went from occupying 2 buildings and 3 floors in those buildings down to half a floor in 1 building. Really kept that footprint for the key jobs like Adam was mentioning earlier, cash posting, kind of mail, those kind of things you just couldn't get rid of. So that we have really a shadow staff that comes in on a temporary basis as the needs are for the week. In Matt's team, for example, we decided to allow one employee who had been with us for a while and she's not interested in going remote. So she still comes to the office every day. We're allowing that at this point. We're not planning to change that. We're not forcing her to go home. But if that staff member were to leave us tomorrow, Matt would recruit that as a remote job. And so it's really been this tremendous culture shift for us. And so I also wanted to address the question, I'll get to your answer to your question in a moment, Will. But from a leader perspective, it totally changed the way we interacted. So I don't know if many of you have embraced things like Teams. Microsoft Teams now becomes our BFF, right? Because not only is it an easy way to share information, chat, do files, do video, do calls, whatever it may be, we now are engaging that. And so when it comes to policy, for us, it is going to be a remote environment. We've had to define some standards around equipment, which actually for us, we rolled out equipment from the organization to the employees. So, provided the hardware, the monitors, the headphone sets, and then probably the biggest sticking point that we learned is to have a minimum speed. When we first went home, we did not have that in place, because we all went home overnight, right? We said, go home on your own equipment, with your own internet, and whatever you can do. And we finally got to that place and looking at our performance. So we worked and partnered with our information systems department. So what is the minimum we need to have as far as a speed in order to be like when we were in the office? And so Matt and his team did a great job for that particular business unit and rolling that out and working with our staff over time to make that happen. And now we continue that through the entire revenue cycle team. So it's been this massive transformation for us, but we're all in, and this is the mode of operation that we're going to go forward with.
So I have a follow-up question to that, actually. Curious, so if you're requiring minimum speed at home, is Piedmont providing that? Are they providing stipends to the employees?
No.
So,
And our argument behind that is, I mean, we have staff members that are no longer commuting from Conyers to Paces, or Athens to Paces, or let's say Paces and Vinings, where we're at. I mean, myself, my daily commute is 45 miles one way. I'm no longer commuting. That commuting savings is offset by the fact that you now have to go purchase high-speed internet and maintain a minimum of 50 megabytes up and down. And arguably, they're still saving money, but while they don't necessarily understand that at face value, we have to have a conversation with them through that. But no, we're not compensating them for having to purchase their internet or anything of the sort. But again, to Andrew's point, we provided them with a home computer, actually 2 monitors, a keyboard, a headset, and a mouse, and it was not cheap to do that. So we provided them with that equipment. So the best they could do is provide their own home internet and that's high speed.
I actually work in a hospital 15 miles up the road. It's incredibly remote and very rural. So in conversations about sending my folks home, I have one that lives, we call it the Valley of Hell. Because it has zero internet.
Oh my.
Or it has such slow dial-up. Yes.
Dial.
What I'm serious.
So I'm gonna let Andrea take that.
That's really maybe you come back in the office.
Well, in those particular situations, there is nothing to do.
Yeah, I think we have to recognize where we're located in all fairness, right? We're in a metro Atlanta area, so our market for talent is different than what it would be in other communities, so there's no denying that. On a personal story though, I live in one of those places, and so I pay through the nose for internet, is what I do, but I'm able to do that, right? So I recognize that. And I think if we had a staff member, because I think we actually had some that were kind of on the outskirts, and we actually worked with them to give them a time period to make a decision to see what was best. So we actually didn't lose anybody. Everybody was able to work out those details.
But we gave them a window, and if they could provide the material inside of that window, then we gave them the option to come back into the office. We weren't going to terminate them, so they had the option to come back
For
to
me,
the
that
office.
was the whole barrier.
Right.
You
And
know,
miraculously, the ones that were struggling, they made it work.
there just is no internet outside of Lawrenceburg. Manchester and surrounding communities have limited access, and so when you're having this conversation, it's like, no.
Was there a question over there?
From a liability standpoint, how do you protect, as a small company, how do you protect yourself from data breaches, equipment breaches, and even what's
Well, I can tell you from Piedmont's perspective, we implemented a very solid VPN, and to the point that when you're on the network, you can't do things like that. So we immediately put a wall, if you will, in place for staff that might have that risk to be able to do that. And then I think you have to be reminded too, because, we talk a lot about productivity management, things like that, and that stuff that's something you have to watch. For our teams, particularly our call center teams, we've got their calls recorded and their streams recorded. So we can do an audit. In fact, Matt and I do that.
Yep.
Just randomly, so.
And on top of that, we got, go ahead.
But from a liability standpoint, in case you become one, what type of coverage works from a workforce?
So in all actuality, there's really no difference from them logging into our network from from their home system versus if they're actually sitting on our office. Everything is logged into through a virtual desktop infrastructure. They cannot access the same sites that they would be able to at home when they're logged into our network. They can only access our network through their computer systems that we send them. So it's really no different than if they were sitting physically in our office inside of Atlanta. So from a liability perspective, I would argue that there is no increased liability because they cannot do anything at home that they would not be able to do in the office.
So for small companies that may not have the resources of big hospitals.
Right.
What's the panel advice supplied to protect yourself?
So I'm not sure that the panel could answer that, but if there's someone in the audience that may be able to answer. So his question is, for a small organization, how would you go about protecting kind of PHI and your organization from the risk of people accessing your systems remotely? Is anyone in the audience able to help with that? If not, we can take it. Yes. Mhm. Right. It times out and things like that, right? So did you hear her?
We do not have.
So I'm sorry, where are you guys from? Okay, so Apollo MD says that they have a 3-factor authentication process, and that it also sends a notification during the day when they're on to verify. Maybe during the session we can talk about that. That might be a good topic for some of the small organizations, so we can bring that back up. Okay. One of the things I will say that this conversation has reminded me of is, so on Monday, now that I live in Atlanta, Georgia, we had a tornado warning, my first, and we had to move our staff down to the basement. And that morning beforehand, our Epic system went down. And so we had a BCA plan, right? So everybody has a business continuity plan. We had that was all focused on people being in the office. And so one of the things I would say, and we need to talk about a lot, but if you have not revisited your BCA plan, now that your team is remote, I suggest you all do that. Otherwise, your staff is just gonna have, fun breakfast at home watching TV because they're not in the office to help you with filing and help you with billing and things like that. It was one of the things that we realized we really needed to go back and revisit. And we hadn't, and unfortunately we hadn't, because we should have, because my boss, who was, and probably most of you don't know her, but she's a slave driver. And she did remote access, before the pandemic. So you wanted to work in her organization because of Johns Hopkins. She had, more than 50% of the RevCycle team was actually at home. So the surprise to us is that we didn't have that plan in place, knowing that,
Because they wouldn't let you send anybody home.
So I'm talking about Sandra Johnson, just so those of you that don't know, inside joke there. So, okay, so I was worried about us not having enough time and we're moving along. So we're gonna go to denials because nothing has changed, right? So we talked about what's new, nothing has changed, denials are still a problem. I'm gonna ask Adam to just start us off talking about, how they're dealing with denials and then specifically on denial prevention.
Sure. So I don't know if everybody saw the Change Healthcare presentation that came out about denial trending and things like that a month ago. But it basically showed since 2016, there's a 23% increase in denials across the board. We're seeing that, and I'm sure my colleagues are seeing that as well in their respective organizations. What the pandemic did was really helped us to come back to focus. Long story short, I think it always gets down to focus. Everybody always asks, what are you doing for denial management? It's always going to be, you've got to focus on certain things and remove the clutter. So the first thing we started back was benchmarking again. We need to be consistent from a benchmarking perspective. What metrics are we looking at? We chose a combination of hfma and MGMA because on the ambulatory side, you've got to kind of have that from a point of service cash collections, different nuances with benchmarking. Then once you get that and you sort of embed that in the culture of your team, you then go to the next step of mapping. because now you're reporting and you're saying more information needed is my top denial, but then you realize when you sort of, peel the onion a little bit, that the remark code associated with that CO16 for more information needed is actually authorization. So really your true problem is authorization. And so once you get the mapping right, you can actually figure out what the issue is. And then you start removing the clutter now that you know what the root causes are because you have those specific denial categories. And then you get to finally focus on revenue generating work. And so we, Ashley, created work use scoring in our work use so that it actually tells the user in their workflow, this account is what you need to prioritize. You don't prioritize that, you're going to get a ding on your quality. So we're focusing them on revenue generating work. So sort of those steps you've got to take, and it's all focused.
That's great. That's really awesome. I like that idea. Anyone else want to share, Richard?
Yeah, very similar to Adam. I think for us, it like Adam, it all starts with the data. Understanding the 835 data in our case, we weren't exactly sophisticated about that, but we've learned in the last 2 years really how to ingest that information and then use it to our business model. Because as a long-term acute care facilities, we tend to be smaller hospitals, but very much longer lengths of stay, very high dollar claims. So you can imagine the opportunities payers will use to deny one or all of those claims, because those stays usually average 20 to 30 days at least. And we've had some that have been in their hospital for a year or so. So we're constantly having to get reauthorizations. And so using the data and the other thing we had to adjust for was our payer mix shift. About 4 or 5 years ago, traditional Medicare was about 60% of our revenues, and everything else was about 40%. That has actually flipped. We are almost only 40% traditional Medicare, and everything else is non-Medicare, mostly because obviously more managed Medicare, more managed Medicaid, and with that becomes the hoops and hurdles with authorization requirements, et cetera. So getting a handle around the data, developing dashboards that really track, monitor, and share with not just the financial areas, but the clinical areas, the chief medical officer, the senior executive team, the owner, private equity owners of the company, share with them the visibility of looking at the data and what the data is telling us, the denials as a percentage of revenue, the denials as a percent of our total claims, the denials as percentage of patient days, et cetera. So really getting into the details of what's our pain points. And then we also have developed payer scorecards to kind of tell us which payers are have more propensity to deny that claim and for what. And then what's our overturn rate with them? Why are we so much more successful with them and not others? And so it's sharing that information with the payers. So really working with our managed care department on that front. Now they deal with primarily contract people, but having that conversation, particularly in value-based discussions, when you're talking about quality, but you can also mention, by the way, 1 out of every 2 of our claims you're denying, and we're overturning that at a 70% clip. So there's a lot of inefficiencies and a lot of wasted time. Let's see how we can work this out together. But I think it's really aligning yourselves to, in our case, better with the clinical area. And they've really, we've really are in lockstep now like never before. And I'm really excited. We also had to subdivide the denials for clinical versus technical. Adam mentioned the mapping. We had to take out, there was a lot of noise. We called it noise in there with duplicate claims, because in our case, we have to send paper bills all too often. I know we're going to talk about that shortly, because the payers are always going to want to review that claim because of the amount of it and the cost of it. And so, it's just interesting to share with them and bring to their attention that, we're providing all this outstanding clinical care and the expected revenue is this, but here on the backside, here's what's happening. Here's the bad debt expense. Here's our AR days with this particular payer because of the challenges with the authorization. So we've tried to change that mindset and pivot from a management perspective to a prevention. So we're really focused on our front end processes, particularly our prior authorizations and our concurrent authorizations. But I think the fallacy about the denials possibly going down because of the waivers is because the prior admission waivers may have been waived, but I can assure you that the payers are going to come at us with audits and retro reviews for those very same stays. and they're going to be looking at the same things such as medical necessity, level of care, and the like. So we're already feeling that a little bit. We're already seeing some payers looking at our claims that had prior authorization waivers, but now they're looking at doing line item details. So these stop loss provisions may not kick in. So on one hand, it was a relief, during that particular time, but we're starting to see the reality of it play out through time.
Okay, so Richard brought up authorization, and so Jennifer, can you share some process flow changes that you made to update authorization?
So I'm sure, like many of you, you have those, hey, the surgeon authorized CPT code A, they go in to do the surgery, and guess what? They added B and C. And then the bill goes out the door, and then you get a denial because we didn't get the authorization updated. So for the past, I guess, almost a year, we've actually been working on the process. And right now, I will say it's very manual. We're trying to get everything worked out, but to make it a little bit more automated, but we have a process where the physician puts the request in for whatever surgery they're going to do with their CPT codes. It goes to a coded review to verify that those CPT codes match the note that the doctor put in saying that this is what we're going to be doing. Then within 8 hours of the surgery, that physician is required to do their op note so that the coder can then go back and re-review and make sure that how it's going to code out ultimately matches what we authorize. If it doesn't, we immediately send that back to the central scheduling team so that they can get on the phone within 24 hours or 1 business day of the weekends to get in touch with those insurance companies and update authorizations. And again, there's a lot of sort of back and forth and manual processes. So we're really trying to hone that down. We've asked, of course, for physicians to say, hey, tell us when you're doing something different. We're not going to smack your hands or anything like that, but tell us when you're doing something different. That way we know right away, as opposed to having to go through all 50 charts of the day and find the one, of course, that's chart number 49 at 4 o'clock and hope that we can get that authorization updated. Where it's been a little bit of a pain point on the revenue cycle side, we have decreased on our outpatient surgeries, our no off denials by probably about 85 to 90%, which is a significant savings on both the hospital and the physician side. So we know the process is working, and like I said, we're trying to really still kind of streamline it. We're going to actually be creating a team dedicated to this as opposed to the coders having to do everything on the front end plus everything on the back end. We'll have a team dedicated to this. We're really getting a lot of buy-in from the physicians because they're starting to see that they're not getting those denials on the back end, and they're not getting sort of their hand smacked for, hey, but you didn't tell us, now we're not being able to get paid. Because no matter what, you all know, I'm sure, that you get the authorization, but you do something different, you get the denial, and there's no question of the medical necessity, because the medical necessity was there. But the insurance company is just going to come back and say, oops, sorry, you didn't get the authorization. So we don't care if it was warranted or not, we're not paying you. So the little bit of the pain point is a little bit of the extra work we're trying to do at the front end is really helping us in the back end in avoiding those denials. Our bi-weekly meetings, we have charts where we used to go over the denial. Now there's really almost very few there that have any denials coming back for no authorization. So it's been really, really beneficial for us.
So the panel had talked about, people working remotely, the opportunity to just have more electronic authorizations and even attachments. So I think that overall people were interested in what people were feeling or finding with more payers adopting electronic attachments or authorizations. Does anyone have any good experience that they can share on that, both in the panel or outside?
Yeah. We actually talked about this and we were all kind of stumped because none of us have really figured that process out to be really successful. We know that availability, you can submit electronic records, but you can only submit about 50 pages in each one of the batches. So if you've got a stay, that's been in there for a year or however long, and the record is 1,000 pages, to try and send everything at 50 pages at a time is crazy. To send 1,000 pages by paper, look at all the printing, the cost to send it in, and of course, I'm not going to name insurance companies.
And
So That, oh my gosh, they never get the record to 7 times. And then finally you call up with a fifth person and they're like, oh, yeah, they're right there. They just never attached. So, we would love to hear any of you guys that have success stories and being able to submit records electronically, submit for authorizations electronically.
Only thing we have been successful with workers' comp and sending attachments. That's about it. That's the only one that will take them electronically without any problem.
I would say Palmetto or Medicare. So they're using the SmartNet.
Oh, yeah.
So if
Yeah.
anybody else would adopt that SmartNet process, probably better. The problem is they only allow 7 days. So now you have your teams like working tremendously fast to turn around those records in so many days. The SmartNet but it does reduce denials. So they'll allow you to put the SmartNet on the claim, you send the claim, and you have so many days to upload those files. They've gotten a process that's worked. No one else will adopt anything similar to that.
That's actually elevated.
Okay.
Jennifer, we've been successful with United Healthcare, because they're my arch nemesis. They don't like, yeah, they don't care because you get here whatsoever. And like Richard was saying, I don't know that we've ever had a year-long patient, but we've had a 4 or 5 month-long patient. So I kind of take an approach of, okay, I'll mail it to you. Put it on your web portal and you can limit it to 10. I must return a receipt and we'll send it through different boxes, UPS, overnight. You can figure it out. Then we had a conversation with UHC and they've opened up their ability to do 100 pages at a time. It's tedious, but it works better.
Did everyone hear that?
Yeah. You heard.
Hey,
So
Bill,
so I'm sorry.
let's say, Bill, these are some good ideas for our fall pair form.
Yeah, so I'm sorry, what organization are you from?
Roosevelt Palm Springs Rehabilitation and the LTAC Hospital.
So she just said she's worked out with UHC a process where, because it was such an administrative burden, they were willing to allow them to upload up to 100 pages. Yeah, of records, which is pretty awesome.
We appealed to their side.
Yeah.
Post-acute care is run very lean, very, very lean. So when you only have 3 billers billing $100 million a year, you better be really. But we fought with it for years.
So that may be something that's worth the organizations coming together.
Yeah.
To partner with these payers. To help with this, as you can see, I'm challenged with that organization since I relocated to Georgia.
One of the things that Richard said is very true is all of our claims are very high dollar. They usually average well over $30,000.
Oh, yeah.
And they automatically get stopped and go into a main.
Well, so at a minimum, most people are using the PWK segment to say, let's suspend it and let's send it, but it's still not a good process, right? It's still manual. Yeah.
So one of the things, I'm the current president of HFMA for Tennessee, so we pulled THA into some of the largest payers across our state to levy and identify the top 10 things. Payers, the top 10 problems with each payer, and are trying to pull that together and levy as a big partner. So that's definitely something
That's the right thing to do. So for those of you that didn't hear, she's, I'm sorry, I don't know her name, but she said that they pulled together the Tennessee Healthcare Association to identify the 10 top issues that providers are having to talk to the payers about. So pulling that put together is really a way to address those issues. It's really great, yeah.
Well, and having your JOCs, your Joint Operations Committee meetings with your payers and making sure that from the provider standpoint, you are prepared with them, because I can't tell you how many I've gone to where that payer, you're having a conversation, you think you have everything, and they shoot you down saying, yeah, but you didn't do A, B, and C. I'm like, yeah, but, well, sorry, you didn't follow our rules. So really making sure that with you have all of your stuff together when you're getting ready to meet with the payers, and really, but show it, bring it out there and show exactly what they're doing, because, we talked about, some of the appeals that they're going through, like downgrading appeals that we know that we're all hitting with E&M levels automatically downgrading. And yet, if we can show, but 90% of them were overturned on appeal, look at all the administrative burden on our side as well as your side, and why don't we just agree to maybe a certain percentage of post-appeal reviews as opposed to stopping payment at the forefront and then go through this whole appeal process?
So as we start to wrap up, I want to talk about telehealth because everybody again, so we talked about, you know, what we're dealing with, we talked about kind of the stuff we have, nothing's changed. Telehealth is really in the forefront of everyone's organization. But the new thing that's happening in telehealth is really about competing with other organizations, right? And so one of the things that I had read was Amazon plans to expand their virtual medical services to all of the Amazon Care for its employees. So in all 50 states, including Washington, DC. And so that brings about, you know, more competition around how do you retain your patients and your revenue. So I really want to talk to the panel about, I'm going to start with Adam, to help me understand, where does that leave your organization? What do you plan to do?
So this whole topic of virtual health is like an Apple event to me, where, you know, it comes out with a new iMac and I'm like, I want to buy this immediately, and then I pre-order it and regret it when I see it hit the cart. But that excitement is always short-lived until, you know, it hits your credit card. And virtual health is the same thing, right? In April 2020, virtual health visits, I think Medicare said Medicare primary care visits, 43% of them were virtual in April 2020. It saw very, very much the same thing at WellStar. Then you see by November, December, now January, February, March, 1%. Literally 1% of our visits are virtual because patients want to come back in and all those types of things. The struggles are yet to be remained. We don't know. We had a whole bunch of restrictions, geographic, provider, barely any reimbursement for virtual health, and we're still relying on an 1135 waiver to get, you know, this in-person visit reimbursement. So we're not even guaranteed that we're going to get money. And so I appreciate all the excitement. I love Amazon too. They're great from a Prime, and Prime Video is great too. But I say let Amazon Care do it first, like they did for a whole bunch of other healthcare things that they've tried and failed. And let's see how they do. I think the biggest takeaway we got to figure out is Amazon Care guarantees that within 60 seconds, the patient gets a response. That's where we need to get at. So the patient's not waiting for a virtual care visit to start, like, you know, the freaking Zoom and Teams meetings we've been on, providers on mute, you gotta know it's 5 minutes. So I think the biggest thing is take away all the patient care aspects, which is speed to delivery, schedule density, fix those things. That's what the patient actually cares about. They don't care about the branding of Amazon Care. And by the way, it's Care Medical, which is a smaller group that's helping with them. The WellStar brand, the Piedmont brands, all of our brands are clinicians that are branded. So we're the ones that actually are serving.
So Andrea, thank you. That's awesome. Andrea, how's Piedmont's, what are they thinking about addressing this competition?
Well, very much is similar to what Adam just shared about, you know, high engagement during the springtime, right? And then it kind of began to change. And I think what we're seeing our physicians today are using it more in follow-up visits. So for example, my father during COVID actually had back surgery. And so he's had several visits with his surgeon since then. And now we're at the point where the doctor just wants to move to the video visits. You know, you think about it from the senior population, that's really an advantage. You don't have travel that you have to arrange for that population. So when you think about competition in your market, that's really an alignment that really can set you ahead when you can embrace that way. So I think that's something that we're still kind of working out those details. But the other thing from a telehealth that I wanted to highlight is just the digital communication increases that. Matt's team alone, just from the customer service aspect, tripled in volume. And we actually had to go back and examine the multi-channels that we had open for patients to come because we had to be able to manage all that inventory that was coming in. And we didn't see a decrease in telephone volume. So I think that was something phenomenal that actually came out of all this change agent of COVID for our environment. At the same time, we saw an increase of physician communications just within our platform. Since we're Epic, we have the MyChart platform. And so that communication and willingness of the primary care doctors, for example, to now use that as the portal to be able to communicate with patients has increased. Now, of course, we still are facing the factor of the adoption from patients. Everybody's totally sold out on that. But we've made it as an organization to really let that expand organically for us and not to actually get a massive requirement for that interaction. But the other thing that we did during this time is we instituted more broadly the e-check-in model within the Epic platform for us. So we went not only from limited areas, we turned it on for everyone. So if you go to one of our scheduled practices, for the office visit, you're coming in for an MRI, a surgery, we now have that ability for you to sign your forms, upload your insurance cards, and pay. And that was a big change agent for us. Of course, many of you like us may have paused a little bit of that upfront collection activity during COVID. When we came back to a state of turning it back on, we actually saw that engagement on the patient's pain increase. So that's been a phenomenal kind of unexpected improvement that we were able to improve because of this adoption this way.
That's great. Anyone else? Anyone else have any strategic ways to make sure you're staying competitive in the market? Okay, you guys need to start thinking. Otherwise, you might as well start right here. Have all your patients. So as I wrap up, I know we're over time and you're between you and I think Luau, right? But again, I think our industry has a tendency to stay behind the 8 ball, right? And so we want to make sure that we're thinking ahead. And I know during and different. And so one of the things that we need to begin to think about in our organizations to be ahead of that is how we get ahead of that and be more forward thinking about how we standardize our data and even how we implement. And so one of the things that she talked about was that they were going to revamp their whole implementation model so they could do it virtually. That's interesting. And so, but people are in that. So we're in the midst of, our professional billing implementation, and largely, everyone is remote. So want to make sure that people are thinking about that, thinking about how you make those changes in your organizations before you have to. Because everything that we've done over the last 12 months have been by necessity, right? How do you stay, how do you survive? How do you stay alive? Things by necessity. And now we're getting to a place where you can really think and be a little more strategic about that. And so as we wrap up, I'll talk about the fact that Lyft just announced that they are going to integrate with Epic, and they're going to have their healthcare coordinators coordinate patient transportation directly from the EMR. And so things like that is the wave of the future. And as you leave, I'm going to ask all the panelists to just kind of say one thing about where they're hoping to see, and this is all on the slide, I don't know if this is coming, but where they're hoping to see their organization take them to. And it could be, a small step, a big step, but it's not by necessity, it's what we desire to bring our organizations to the next place. So I'm going to throw Andrea right in there as the first one, because she's always ready.
There's a question, so let's just go to that.
Okay.
So, out of curiosity, even though all these people have switched to a whatever you want to call it, we've actually seen, we've seen an increased amount of time that we've been held on wait for UHC and Blue Cross Blue Shield. Has anyone else seen that? Because as much as we think that the more people
Everybody
need,
has.
we're integrated, we've actually seen a lot longer wait times.
Yep.
So how do we
Another way
combat
not to
that?
show you.
What's the answer to that?
Anyone have any suggestions on how to combat that? So it looks like there's consensus that you're not alone. It wasn't just your team saying that they were on hold. Everyone's feeling that. Any comments on how to combat that? Yes.
A lot of people in the organization
So for those of you that didn't hear the other side of the room, she just basically said, make sure that your administrators are pushing more of your users to portal access so that you can do as much as possible via the portal so that you're really reserving those people that need to make the phone calls to a limited few. Yes.
Ensuring that you are pushing your reps who are calling payers to address as many claims as possible while they're
Yes.
on the phone.
Absolutely.
And then we are also leveraging robotic process automation to address some of those barriers.
That's awesome. That's awesome. Yep. Okay, so we're going to wrap it up. So, Andrew got out here. So we can have that conversation after, but I do want you guys to think about, again, how you get ahead of the changes. Like I said, not out of necessity, but because now you're able to breathe a little bit. And thank you so much for attending our panel and enjoy the luau.
I'll see you.